Begins our week 15 study of the endocrine system. Remember last week we did the voiceover PowerPoint for diabetes, and we're going to continue to discuss the endocrine system, things like, the pituitary gland, thyroid, adrenals, those kind of things. So diabetes was last week, again with the, pancreas and the complications of diabetes type 1 and 2. This will be a continuation. So the endocrine system is a negative feedback system. That means that when the levels are low, the body wants to start increasing the production of that particular hormone. We have included a website here, so take a look at that so you can understand a little bit better about that negative feedback loop. Here are some of the glands we're going to be looking at. Pituitary, thyroid, adrenal. These are not the only glands. These are not the only diseases, but we're going to focus on these ones because these are the ones you're probably going to see the most. So we've also included a YouTube video link down below. Take a look at that, and that will definitely help kind of identify some of these glands. Our pituitary gland is known as the master gland. It helps control and organize what the other glands are doing. We have talked about the pituitary before in, let's see, semester 6. I know we talked about it in pharm, that the hypothalamus is creating oxytocin, but it is regulated and distributed through the pituitary gland. So you've heard of it before, you've seen it before, but this is a big one. And just like any of these, you can have too much or too little. So again, our hypopituitarism or our hyperpituitary disorders. So this really affects our growth, our sexual and reproductive development and functions. It regulates, thyroid gland, adrenals, and the gonads. So again, if you hear about the master gland, that is definitely our pituitary, and we'll touch on that. So if we do not have enough of our pituitary function, so if we have decreased function and the hormones that are associated with the pituitary gland, we have all of these listed here. The next slide actually goes into a little more detail about those. We're going to see some deficiencies. So specifically, if we have children, before the closure of the epiphysis, dwarfism can develop. A lack of growth hormone in adults does not affect bone length, but it does affect like bone density and osteoporosis. These things may develop. Hypopituitarism and the clinical manifestations, it kind of depends on what we're missing. If we have decreased ACTH, we're going to see changes in our cortisol level, our inability to handle stress, hyponatremia, hypotension, hyperkalemia. Our growth hormone, we can have weakness. It also really can cause a decrease in bone density, decreased muscle strength, and increased risk of bone fractures. Our luteinizing hormone, that is where we see that irregular menstruation and amenorrhea for females. In men, you can see a lower level of testosterone. These are hormones they typically check around menopause to see if we are still producing enough hormones, because if we're not, they're probably going through some changes. That includes our follicle stimulating hormone. If we have low levels of that, we're probably not producing the estrogen. We're going to have decreased ovulation and decreased sperm count. Our TSH we'll discuss when we talk about the thyroid. But again, if you have very low levels of TSH, you might have weight gain, thinning hair, and decreased libido. When we look at the hypopituitarianism diagnosis and treatment, one thing we want to focus on is knowing which hormone is deficient and to target that specific hormone for replacement. We also want to look at is there a possibility of a tumor? Because if we have a brain tumor or a pituitary tumor, that can definitely affect how our hormones are being controlled. So they may look at a CT or an MRI. We're definitely looking at maybe a stimulation test, prolactin tests, growth hormone provocation test. These are also evaluated through blood tests. We may treat with hormone replacement, supportive therapies, growth hormone. We will have to do some supplementation. So growth hormone is kind of difficult to manage because we have different levels throughout the day. We may need supportive therapies such as fluid and electrolyte replacement, and we want to manage growth hormone because of that bone density and that risk for osteoporosis. Interventions include assessments, actions, and teaching. We want to understand the signs and symptoms of that hormone deficiency, depending on what it is. We want to make sure we take vitals, understand that there may be some osteoporosis, decreased bone density, and we want to be aware of that and educate our patients definitely to be aware of falling. If our patients are younger, definitely changes in fertility. I would talk about those complications because if they have low, follicle stimulating hormone and they're not ovulating, that doesn't necessarily mean they shouldn't use birth control. It just says that their chances of getting pregnant are harder, but certainly not impossible. You don't want a surprise. So I know some folks, again, when they have these deficiencies, they may only be ovulating every few months. Yeah, but you don't know what month that is, so you want to be careful. So safety measures, increased vitamin D and calcium, whatever hormone replacements, collaborate with physical therapy. Again, if we can strengthen them bones, if we do some weight-bearing exercises, we're going to have, stronger bones. Teach signs and symptoms of acute adrenal insufficiency. Make sure we're taking our hormone supplements in the morning and our safety precautions. If we have hyperpituitarism, then we could have something called acromegaly. These are our great big people. So if you have a really high level of growth hormone, these are those folks that are, 7'5", super, big human beings, kind of larger faces. Some people had maybe suspected that Abraham Lincoln had some acromegaly. This guy here on our picture, as you're looking at him on our right, the great big guy, it's Andre the Giant. So if you're old like me, you remember Andre the Giant, or if you've seen The Princess Bride, he was in that movie. Very, very big guy, and he was a wrestler. I have to look, but I think he was definitely maybe over 7 feet tall. But you could see him sitting next to this person. He is just very, very big. So definitely look at your clinical manifestations. Understand that maybe these hypersecretions can be related to a tumor. You are more likely to have these issues if you're female and you have kind of surplus of these growth hormones, thyroid stimulating hormones, and others. With our hypopituitarism, we have these clinical manifestations. So it depends on which hormone it is. So, with the first one here, hypoglycemia, cortisol, hypernatremia, hypertension, hypokalemia, growth hormone, you can have increased bone density, of course, facial features, irregular menstruation, a thyroid stimulating hormone, we have weight loss, and we have the exophthalmos, I'm going to say it wrong, but that's where we have those kind of bulging eyes that are really associated with hyperthyroidism. Again, we'll go into that when we talk about the thyroid. Complications, hyperglycemia, hypertension, acromegaly, thyroid storm. So all of these are very concerning and we need to be aware. So when we have hyperpituitarism, we often have to do surgery. That's where they'll either go in through the nostril or they'll go in above the top lip, and they'll take a basically a long skinny tube and go up to the pituitary gland and clip it. It's very, it's a very significant surgery. It's easy to do, but it's definitely, we're messing with the brain, so it's not, it's concerning. So they're going to remove possibly the pituitary gland. That's a transsphenoidal hypophysectomy, and this is one where they're going to have to then replace those hormones afterwards. But if it's, if we've got way too much, we've talked about this before, too much is still too much. We want it to be an appropriate amount of hormone level, and we're going to have to do replacement. So let's do our stimulation test, our provocative test to look at where we're at. If we're too high, then we're going to have to do that surgery, the transsphenoidal hypophysectomy, and I'm pretty sure I stumbled over that one, where they remove the pituitary gland. Nursing interventions for hyperpituitarism. Definitely look at our assessments, our vital signs. We're watching for hypertension. The neurological assessment, including vision. Pituitary tumors can cause an increase in intracranial pressure, and as tumors enlarge, they can cause visual disturbances and headache. We want to look at input-output, daily weights, electrolytes like sodium, potassium, fluid overload, changes in the size of their hands, feet, bone structure, increased growth hormone causes the thickening of bones, neurovascular status. Patients with acromegaly, bone growth may compress peripheral nerves, causing numbness and tingling or pain in the hands and feet. Joint pain is expected. Administered dopamine agonists will inhibit the release of the anterior pituitary hormones. Somatostatin analogs, they inhibit the growth hormone. Supplements. We need to replace sexual hormones if it's required to facilitate normal functioning and conception. This is an image of a transsphenoidal hypophysectomy. This is where they're going to go in and cut the pituitary tumor out. So you can see, it's kind of sublabial. We're going to make an incision in the top lip and move it up through the nasal cavity. Nasal septum, it kind of moved to the side, and the sinus is opened, so then you can get into that pituitary. We do want to educate them about the signs of meningitis. A surgical approach does increase that risk of meningitis, so we need to monitor temperature, nuchal rigidity, and photophobia. We want to look at signs of diabetes insipidus and notify the healthcare provider if you have increased urine output and excessive thirst. We want to notify the provider and make sure we're aware of the signs and symptoms of fluid overload. Instruct the patient to notify the healthcare provider for weight gain. We must understand the pathophysiology of this disorder and really understand the fluid volume balance and how that's going to affect a patient. We want them to use a soft toothbrush. Again, we want to kind of avoid that intracranial pressure, and we want to make sure that we're evaluating for things like we want to avoid coughing, sneezing, bending at the waist. This would put strain on the surgical site. We don't teach patients that have had this surgery coughing exercises. Deep breathing is okay, just not coughing. We want to report any increase in the drainage of clear fluid in the nose after this procedure, because it could indicate a cerebral spinal fluid leak and definitely increase our risk of meningitis. We're going to continue on to thyroid disorders. The thyroid is a gland, kind of a butterfly-shaped gland in the throat. There are some very common disorders. You're going to see the hyperthyroidism, hypothyroidism, and possibly thyroid cancer. These are, very common. You're going to see a lot of medications and a lot of patients that have this, and you may see people that have that thyroid cancer and that scar that's across their throat. So we'll get into this right now. What's the thyroid? The thyroid is that gland, like I said in the previous slide, butterfly shaped, that sits on the throat. When it gets swollen, you know, obviously it can lead to goiters. This is the gland. It kind of regulates metabolism. There are there's 3 hormones that are kind of regulated. One is the thyroid stimulating hormone, and the others are the T3, T4. They got big, long, fancy names. But what we want to do is understand that we need iodine to produce 3 and 4. So too much iodine can cause hyperthyroidism. Too little iodine can cause hypothyroid, and that's where we get the goiters. When we look at our measurements, when you're actually looking at the lab slips, you have to understand that if we have too little thyroid stimulating hormone, that means we have a lot of thyroid hormone. Okay, so the thyroid stimulating hormone is what tells our body we need more. So if we have very, very little of that, that means we have a lot of, you know, T3 and T4. So you'll see this inverse relationship. So low TSH means you have hyperthyroidism. If you have a really high thyroid stimulating hormone, typically you have very low thyroid hormone, because your body is saying, hey, we need it, we need it, we need it, we need it, and you're not getting it. So that's when you see a very high thyroid stimulating hormone, so TSH. So definitely understand that those are reciprocal relationships. You know, when one is high, the other will be low, and vice versa. Thyroid labs, our total T3, total T4, and then our thyroid stimulating hormone. So definitely understand high T3 and high T4 with low TSH indicate hyperthyroidism. Low T3 and T4 and high TSH indicates hypothyroidism. Hyperthyroidism is one of those disorders when you have too much thyroid hormone. You have an intolerance to heat. You could have the bulging eyes, facial flushing, finger clubbing, diarrhea, muscle wasting, increased blood pressure, some edema. These are very, very common effects. These hyperthyroid people are not comfortable here in Phoenix because it's super, super hot. I have had a good friend of mine who has hyperthyroidism, and she had very, very pronounced eyes, you know, and that was definitely a very common sign. I would definitely know the difference between hyper and hypothyroidism and the signs. You will see those again on an exam. Okay, so here is our hyperthyroid person. You know, we have a lot of thyroid hormones. It's very common in women. You know, we can have these folks probably a little skinnier because they have that really accelerated metabolism. We have a high T3, high T4, low TSH. You know, if we have goiters, you may want to have a thyroid scan. Hyperthyroidism can be present kind of at any age, but it's usually diagnosed between 20 and 40. It is 10 times more prevalent in women. We often call the autoimmune version of hyperthyroidism is Graves' disease. So it causes the hyperthyroidism. It results in that enlargement of the thyroid gland and subsequent hypersecretion of the thyroid hormone. Graves' disease, again, is synonymous, kind of the hyperthyroid version of it. Disease, you can see this gal here, she's got very pronounced eyes. It looks like she's staring at you, like her eyes are kind of bugging out of her head, just staring very intently at you. And again, like I said, my friend who I used to work with, she had very pronounced eyes, and that was just part of the Graves' disease. This is autoimmune. It is a hypersecretion of those thyroid hormones. Usually you're just, it's genetic. You end up developing this. Signs and symptoms are that thalamus, I'm going to say that wrong, sorry, but that's when the eyes are protruding. You can have a goiter, signs and symptoms of, typical hyperthyroidism. Well, what do we do? What do we do if people have way too much thyroid hormone? We're concerned because we've got that hypermetabolic state. We need to manage the clinical manifestations. We have to look at that fluid intake, promote quiet, non-stressful environment. Typically, we get those anti-thyroid medications, iodine preparations. We want symptom management, so possibly beta blockers. And, probably a thyroidectomy. Depends on how bad it is. Uncontrolled hyperthyroidism can cause something called a thyroid storm. Not good. So for long-term management, they're going to use these different medications, a PTU, methimazole, lithium carbonate, medications to reduce these clinical manifestations. They interfere with the formation and the release of the thyroid hormone. So for short-term management, iodine preparations may be administered, particularly for patients before a thyroidectomy to decrease blood flow through the thyroid gland and in order to decrease the thyroid hormone release. And I actually had a student last semester who had had to have her thyroid removed because she was having so many issues. Super sweet gal. In semester 5, she had been noticing she was shaking. She was just really struggling with focus and concentration. And they thought, oh, well, you're in nursing school, so of course you're nervous and you're stressed out and all this stuff. She says, no, this is something different. There's something wrong. So she had her blood drawn. She had super high levels of TSH, low levels of TSH, indicating that she was very, very high in her thyroid hormone. So they had kind of waffled back and forth on giving her a thyroidectomy. Eventually it got really bad, so she had to have it. I think it was emergent. It was kind of like, oh, nope, this is coming out today because you're having a lot of problems with it. So now she's feeling a lot better, but again, these folks they just really don't feel good. This is it messes with your whole body and your metabolism, and you feel terrible. So definitely take it serious and take the medications appropriately. This is a thyroidectomy, and you look and you can see that there's different types. You can have the entire thyroid taken out. You can have just the part that has the swelling in it or the cancer or whatever. Again, the problem is we want to look always, every time you're doing something on the throat, we want to look at the airway. We want to look at the thyroid storm. So we're going to evaluate, what our labs are after we've had this, because we're going to have to adjust. They're probably going to be on medications the rest of their life. With the thyroid, we also have our parathyroid. If it's damaged during the surgery, we can have hyper or hypocalcemia. We also have to look at possible voice changes. Hopefully there's not laryngeal damage, but it is possible. So if a patient has increased swelling at that site, what are we going to monitor for? I hope you said O2 and respiratory status, definitely looking at that airway, making sure we're not having some sort of rebound swelling where that airway is blocked. Thyroid storm is a disorder that is when we have way too much thyroid hormone. It can manifest by having things like delirium, hyperthermia, hypertension, vomiting, tachycardia, dysrhythmias, pain, dyspnea, altered level of consciousness. In clinic, I have seen this a couple times. I've seen one person that was highly symptomatic, and then I saw one fella who just said he felt a little off. When we ran his numbers, he was definitely very, very, very high and risking the thyroid storm. We tried to get him to go to the hospital. I I think ultimately ended up going to his doctor's office and they told him the exact same thing. So this is deadly. It's usually because we haven't managed this hypothyroidism very well. Thyroid, ectomy complications, illness. We definitely need them monitored. This is something that they have to, we have to intervene on. Airway management, fluid resuscitation is a priority. We are going to get the medications administered with some iodine preparations, beta blockers for tachycardia, maybe some steroids to suppress those thyroid hormones. Cooling blankets may be used to treat the hyperthermia. So we definitely need to intervene. This is a case where, and I would say all of your patients are this way, what are they symptomatic for? So if they have high thyroid hormone and they're really doing well, we still need to watch out for this. We need to have a provider know. It's something you have to do something for. If they're highly symptomatic and struggling, obviously they need to go into the hospital. Are our hyperthyroid nursing interventions, vital signs, that's not surprising, our eyes and nose, visions, what our hormone levels are they showing signs of goiter? Seizures, we need to get weights. Let's make sure they have their medications and their iodine preparations, any cooling measures, and some eye lubricants. We're going to look at the temperature. Elevated temperature should always be reported. Educate the patient to disease process. We want to take the medications at the same time of day, and ask yourself, why do we want to take meds at the same time of day? As you have had, now you're closing in on your second pharm course, you should know that, hey, we want those therapeutic levels to stay the same, and hormones, of course, fluctuate. So let's try to keep it consistent. We want to make sure they're having enough calories and reporting any palpitations. Here is our person with hypothyroidism. This is extremely common. You'll see this a whole bunch, especially in the elderly, as they we have a change in function from our endocrine glands. As we get older, they have an intolerance to cold, receding hairline, some facial and eyelid edema, hair loss, apathy, lethargy, dry skin, anorexia. There's a bunch of signs here. I would absolutely know for your exam the difference between hypo and hyperthyroidism. So our hypothyroidism is diagnosed by low T3 and T4. The TSH may be high or low. The most common form is Hashimoto's. It's an autoimmune disorder that attacks the thyroid. It may also be caused by too little iodine in the diet. So primary hypothyroidism develops as a result of a disorder with the thyroid gland. TSH is increased because of the negative feedback loop. So remember, the body is trying to have it produce more thyroid hormone. So it has that thyroid stimulating hormone and it kicks it out, but the body is not responding to it. So we have very high levels of TSH, but the other hormones are low. Secondary hypothyroidism is caused by a disorder of the anterior pituitary gland. We know it is secondary hypothyroidism when the TSH is low. TSH is secreted by the anterior pituitary gland. If your hypothyroid patient complains of trouble ambulating, who might we include in this interdisciplinary team? If you thought of physical therapy, you were correct. We also want to be on the lookout for mixed edema. So patients with hypothyroidism can have mixed edema. This is a condition that causes osmotic edema and fluid collection that's associated with generalized non-pitting edema. It can lead to decreased cardiac output. Decreased gastrointestinal activity results in constipation and abdominal distension. Skin changes may result over time secondary to cold intolerance, and a lack of sweating may leave the skin dry and coarse. So remember, hypothyroidism, if you're way super low, we're looking at mixed edema. With hyperthyroidism, way too high, high, we're looking at the thyroid storm. So look at your extremes and know what they are related to and which disease process they're related to. So our hypothyroid treatment really kind of revolves around the replacement of that thyroid hormone. Understand that if they've had a surgery to replace or to remove the thyroid, they will always be in hypothyroidism. There's not some other replacement or some other organ that's fixing this. They have to be on thyroid hormone. Usually it's the levothyroxine. Sometimes you might see them on Armour. That's a natural, I want to say it's either pig or cow, and they grind up their gland and create it. It's not necessarily the most regular and regulated, but some people like it better than the levothyroxine. So Armour, levothyroxine, you'll see. The goal is to stabilize the thyroid function. So when we're starting this, we started at a low dose and we increase it as needed to treat the symptoms. The thyroid hormone affects metabolism, so the medication is to be taken in the morning. This is on an empty stomach, and it's usually before anything else, at least an hour before. So our night nurses were the ones who gave our levothyroxine at 6, because then when we came in at 7, by the time we got vitals and all that, they were ready. They had a good 2-hour window so that levothyroxine could be absorbed. So this replacement therapy is a lifelong regimen. It is important for the patient to take the medication at the same time every day. Additionally, it is important for the patient to inform all healthcare providers of his or her history of hypothyroidism and the dosage of the hormone replacement. They're going to have to follow up with a physician. They're going to have this evaluated probably at least every 6 months to make sure that their medication is appropriate and they're not getting symptomatic because maybe they need more or maybe they need less of this treatment. Patient with the myxedema coma, it's not common, but it is a rare and life-threatening complication. It's when we have super, super low thyroid hormone. This person presents with hypoxia and carbon dioxide retention secondary to hypoventilation. Because of the significant decreases in cardiac function, the patient is bradycardic and hypotensive, hypoglycemic, hyponatremic, and they're going to have significant hypothermia. Patients are particularly sensitive to sedatives, analgesics, and the anesthesia agents. Metabolism of these medications is significantly lowered, so definitive treatment is aimed at replacing the thyroid hormone and supportive measures. For hypothyroid nursing interventions, we definitely want to look at our assessment, see what our O2's at, our vital signs, our serum calcium levels. Again, ask yourself why calcium. Maybe if that thyroid is not working very well due to a surgery or injury or cancer, there is a high likeliness that the parathyroid is not working very well. So we need to check those calcium levels. Daily weight, skin texture, color, turgor, and monitor for the side effects of medications. Actions, we have to get that thyroid medication administered, and hopefully at the same time every day. We're going to use narcotics and sedatives with caution, provide warming blankets, and turn and reposition. Vitals are the priority nursing intervention due to bradycardia and the slowing of all body systems. Hand tremors can result from thyroid replacement. This indicates the need for a dosage adjustment. Our patient education revolves around making sure they understand how to take their medications as they're prescribed. It should never be stopped abruptly. We should stay on the same brand and the same dosage. Anything that's changed, we need to kind of wean them slowly. Immediately report chest pain or discomfort. We want to educate them to the signs of hypo and hyperthyroidism. Just remember, if we're replacing that thyroid hormone because someone is hypothyroid, they have low thyroid hormone, then it's really easy to swing them in the opposite direction, and now they have hyperthyroidism. So let's educate them like, hey, this is what it's like if it's too high, This is what it's like if it's too low, especially in the very beginning if they've just been diagnosed, because they may not know what the symptoms are. They may be somebody who says, hey, I take 1 pill, it's good. Then maybe if I take 5 pills, it's better. We have to educate them that we need to keep those levels within a certain range versus that more is better attitude. They need to understand both hypo and hyperthyroid, regardless of what their diagnosis is, because it's very easy with medications to swing them in the other direction. If the patient is having trouble coping, how do we help them? We educate. The most important thing here, just make sure they're taking their medication as prescribed every day. So one of the reasons that people can have issues with their thyroid hormone is because of thyroid cancer. So these are when you get those nodes or that enlargement of the thyroid, it can be cancerous, and so it does need to be examined. The tumor is usually something you can feel, and they're going to do a thyroidectomy. It could be a complete thyroidectomy, it could be a partial. It really depends on the physician and their requirements, what they feel is most appropriate. So as you can see from this picture, as you're looking at it, it's on your right side, that thyroid tumor. You should be able to feel this because that skin is really thin. Where do we typically palpate a tumor of the thyroid? Most of the time you can feel it over what's called the isthmus. If you look at the gland, you see it's kind of butterfly shaped. Right there in that center where the two wings meet over the windpipe, that's the isthmus. That's typically where we feel it. And you can even sometimes see it. So, when you're doing an evaluation, if someone feels like they've got like a little lump, take a look, feel it and see what's going on, and bring it to the doctor's attention. It needs to be addressed. When we talk about the thyroid, we have to talk about the parathyroid, because we know that those glands are associated with the thyroid. They're physically on top of the thyroid, and they are responsible for our calcium levels, different issues in the body. So if there's a problem with our parathyroid, we need to address it. First, let us look at the hyperparathyroid disorder. A lot of those are caused by adenomas. Most common in women over 50. It does result in an increased serum calcium level. Our parathyroid plays a key role in the regulation of those calcium levels in the blood. It's very important that they are precise, because small changes can cause muscle and nerve problems. So, bone is broken down to release calcium, bones become frail, kidney stones, calcium can also build up in the stool. Secondary disorders most often observed in patients with chronic renal failure and chronic malabsorption of calcium. Diagnosed when we have high parathyroid and ionized calcium, they say that you're given a diagnosis of hyperparathyroid. If someone has frail bones and decreased mobility, what's the safe way to move them in the hospital? What are we concerned about? Yeah, definitely injury and falls. The best way to move them is lift sheets and mobility aids. We may have some severe weakness. We want to make sure that they're not getting injured. What are the signs and symptoms of hyperparathyroidism? We're going to see very high levels of ionized and serum calcium. We're going to see decreases in serum phosphorus. Remember, those have a reciprocal relationship. We're going to see muscle weakness and atrophy, low back pain, a possibility, of these fractures, because it's not staying in the bone, it's staying in the blood. Ventricular dysrhythmias, constipation, anorexia, nausea, vomiting, kidney stones. So that's miserable. When we treat hyperthyroidism, what lab indicates that we're having improvement? So if we need high calcium levels to diagnose hyperparathyroidism. If we have decreased calcium labs, then we know we have an improvement in our parathyroidism disease. Our nursing interventions involve assessments, action, and teaching. So with our assessments, we're looking at our calcium and our phosphorus levels, our cardiac monitoring. Remember that calcium plays a role in the cardiac function, acid-base status, pain, and bowel function. Our actions involve increasing fluid, administering Lasix, administering oral phosphates. You could have some calcium binders. We want to use a lift sheet and strain the urine. Specifically if we're straining the urine, we're looking for stones. We're going to do teaching, and we want to show them the signs of hypocalcemia. They're going to have a low calcium diet, and we need to have them increase their fluids and their fiber. Let me ask you, why does furosemide help excrete calcium? So it's a diuretic, so it kind of pulls the fluid out of the body, which is really great. It also will pull, all of your electrolytes out with it. So if you have really high levels of calcium, it'll help that pass through the urine as well. We look at our hypoparathyroidism. That means we have low parathyroid hormone, and the most common cause is usually that the parathyroid is removed or it has been damaged in some way. A lot of times if you have a thyroid tumor, they end up damaging it when they try to remove the tumor. So the parathyroid hormone is not being secreted. Calcium is not being released from the bones. It's saved in the kidneys. It's not being released from the bones, saved in the kidneys, or absorbed. Sorry, my dogs are going nuts. Or absorbed in the GI tract. So vitamin D is not being activated to increase calcium absorption. They're going to diagnose this with, blood levels. They're going to have low calcium, high phosphate, and low parathyroid hormone levels. Are our signs and symptoms of hypoparathyroidism? This is where we take blood and we have low serum calcium levels. We can have tetany, muscle cramps. We can have a positive Chbostik's or Trousseau sign. So familiarize yourself with those. You've got the blood pressure cuff that's squeezing, and it's causing that carpopedal spasms. We can also have the Chbostik sign, which is when you kind of twitch in the facial muscles in response to that tapping of the facial nerve. We can have paresthesia, hands and feet, tingling, seizures, QT, interval prolongation, resistance to digitalis, linked to loss of inotropic effect. So that's your digoxin. You'll find that your cardiac meds, especially digoxin, is not working as well. Hypotension and cardiac dysrhythmias, bone pain, and skeletal deformities. Interventions include assessment, actions, and teaching. Again, let's look at our vital signs, our cardiac monitoring, calcium, magnesium, our acid-base status, neuromuscular activity. All of those need to be assessed, and we want to make sure that they have their calcium and vitamin D if it's appropriate. Teach them how to take their meds. We're going to have them eat foods high in calcium but low in phosphorus. And we're going to teach them the signs of both hypercalcemia, hypo and hypercalcemia. It's a case study to review. Here's Patricia Matthews. She's a 28-year-old administrative assistant who presents to her FNP with complaints of weight loss, despite eating regularly, restlessness, insomnia, and changes in her menstrual cycle. Take a look at her labs. Make sure you kind of look and see what's normal and abnormal, and get kind of an idea of what you're thinking could be going on with this young lady. So as we look at the case study, we can see that the thyroid numbers are off. We can see that her T3 and T4 are elevated, and her TSH is low. So we think she has hyperthyroidism. So her body is creating too much of that hyperthyroid or the thyroid hormone. So the nurse practitioner prescribes the PTU. She is instructed to have adequate fluids and monitor her weight weekly, and she is scheduled to come back in 4 weeks. So these are definitely things we're going to want our patients monitored. These hormones fluctuate, especially when you're first starting to get on these hormone regimens. It's just very important to make sure we're doing enough or we're not doing too much. So she's going to follow up in 4 weeks. So Miss Matthews returns to the clinic 2 weeks after starting the PTU because she continues to have the same complaints of restlessness and insomnia. She's lost another 6 pounds. The nurse practitioner discusses the option of radioactive iodine therapy, but she is not going to go with that because she would like to get pregnant, 28 years old, so she's ready to have children. She just wants to make sure the hyperthyroidism is controlled first, so radioactive iodine isn't in the choices. So what is her next option? We don't want to try the medications. We are going to refer her for a surgical consult. It is likely that she'll undergo a partial thyroidectomy and then remove that part of the tissue that is hypersecreting. The nurse receives handoff report for a patient with a history of hypothyroidism. Which symptoms should the nurse ask about to determine how well the patient is managing the illness? So look at these 4 choices, and you can pause this and then we'll review. The answer is C, constipation. These other choices look like they are hyperthyroidism. So constipation, if the patient has slowed metabolism leading to constipation, we know that that hypothyroidism is not being treated, or it's not treated, well enough. The patient with hypothyroidism is on thyroid replacement therapy. The primary health care provider instructs the patient to take the medication in the morning at the same time every day. Which is the rationale for this instruction? Please pause and then we'll go over the answer. The answer correct is A, to mimic the normal circadian rhythms. So normally you would have a little more thyroid hormone in the morning. That's when you're taking your pill. So it should mimic, the way the hormone is working in the body. If we take it late at night and it's trying to mimic someone that's got higher levels of thyroid, you could cause insomnia. So we definitely want to mimic the way it normally works in the body. Patient is admitted with complications from poorly maintained hypothyroidism. What symptoms should the nurse anticipate? Pause here and then we'll go over the answer. The correct answer is B as in boy. So A, tetany is going to be associated with hypoparathyroidism. Renal stones will be associated with hyperparathyroidism. Graves' disease will be associated with hyperthyroidism, not hypothyroidism. So hypoventilation is the only answer it could be. So definitely know your difference between your signs and symptoms of hypo, both thyroidism and parathyroidism. Patient reports insomnia, weight loss, increased appetite. The laboratory of the patient reports elevated T3 and T4. Which actions are the priority? Please pause here and then we'll go over the answer. The answer is B as in boy. We're going to manage that cardiac function. So obviously kind of take a look at what's the most serious thing that could happen. Dysrhythmias, very serious, so that's going to be our priority. Teaching a patient with hyperparathyroidism about treatment strategies. Which statement by the patient indicates the need for further teaching? So the correct answer is D, as in dog. I will increase my intake of antacids containing calcium. So a lot of antacids contain calcium, and if they're doing a lot of antacids, they've already got hyperparathyroidism, which we know makes them have very high levels of calcium in the blood. So if they take more calcium, they're at a risk for really aggravating this disorder and making it worse. So your correct answer is D. This question's a little tricky, but I like it. The nurse suspects laryngeal nerve damage in a patient who has undergone a thyroidectomy. Which symptom supports the nurse's suspicion? So your answer, correct answer, would be A. Now, I know it's kind of tempting to say, difficulty breathing or, bleeding or something like that, but look at what the question is asking. It's asking about laryngeal nerve damage. So breathing doesn't really have a lot to do with the larynx, but hoarseness of the voice does. So always look and make sure, what is the question asking you? So instead of kind of having a knee-jerk reaction going, oh yeah, I really need to suspect this, I think we have some laryngeal nerve damage, we're looking at a hoarseness of the voice. A patient with hypoparathyroidism has a positive tryptophotic sign. Which statement by the patient indicates a need for better understanding with this condition? So the answer is C. Phosphorus binds with calcium, and it will continue to decrease that calcium further. So we know hypoparathyroidism, you have low blood calcium, and we do not want it to go lower. So your answer is C. C is the correct one. Nurse suspects hypoparathyroidism after reviewing the laboratory report of a patient. Which findings support the nurse's suspicion? Select all that apply. In this, we will see the answers will be A, D as in dog, and E as in elephant. The nurse is assessing the health record of 4 different patients. Which patient's medical report indicates a risk for laryngeospasm? Your correct answer will be A. Our normal calcium level should be 8.5 to 10.5. And all of these are mostly normal, but we definitely see with this super low A, we know that that is going to be at a very high risk for laryngeospasm. Presents to the emergency department with the symptoms presented in the image. What additional assessments should the nurse perform? So looking at the patient and their symptoms, we are suspecting that this person has hypothyroidism. So the correct answer would be A. You would look at their vital signs to see if they have bradycardia. Hypothermia, we want to see temperature, and if they've had a history of recent weight gain. And those would definitely support a diagnosis of hypothyroidism.